Welcome to the Heal, Thrive, Dream podcast, where trauma survivors become healthy thrivers. Each month, we'll feature a theme in the trauma recovery and empowerment field. To promote your recovery, healing, and learning how to build dreams, here's your host, Karen Robinson, transformational coach and therapist.
Hi, everyone. Welcome back to the Heal, Thrive, Dream podcast. Today, our guest is Dr. Jen Blanchette. She is the host of the TBI Therapist podcast. She has a clinical practice in Freeport, Maine, where she specializes in transformative therapies such as EMDR, Gottman couples interventions, and biofeedback. For the past 10 years, she has specialized in therapy after head injury, trauma, and spiritual concerns and mental health. So you will be hearing today about TBI, traumatic brain injury. And she's also going to talk about TBI and domestic violence and just lots of other goodies that I'll let her explain. So welcome, Dr. Blanchette. Thank you for being here.
I'm so thankful to be here today.
Okay. So I imagine I botched your bio. I sometimes talk too fast at the beginning.
You're fine.
Anything you want to add to it?
I live in the great state of Maine, which you're from. So I think we need to highlight just how beautiful Maine is, especially in summer. So if you're, I did have it in here. I taught a fitness class. So my peonies are blooming. If you're on video, you can see my beautiful peony. So I love to garden and be outside and engage in mindfulness. And I'm an avid tennis player. So, and I teach Zumba. So that's why my sound, we had a long time getting on here. My sound was a little botched, but I fixed it. So we're good.
Yeah, and just to tell the audience, before we started recording, we discovered that Jen is from Virginia and lives in Maine, and I'm from Maine, living in Virginia. So I thought that was extra cool. She probably thought it was just.
I did. I thought it was whoa.
Okay, so we talked a little bit at the beginning before recording about trauma, and I think even though maybe child abuse wasn't as part of what happened to you growing up, you mentioned having some trauma. What of your traumas are you willing to share about today? Because I think it helps just connect with my audience who are mostly trauma survivors.
Yeah. And so I kind of think through the big T traumas and little T traumas. And I don't know if you talk about that kind of language on your podcast so much about maybe how people talk about that. So big T traumas, potentially like life or death situations, feeling or where your life was threatened or you witnessed a life-threatening situation or a situation of violence. And the other ones, like more the little T traumas, I call those, are like relationship ruptures or a moment where your body felt like it was in danger, but it may not necessarily be in danger. So I'm going to put that there just to say that some of mine fall into some categories. So one of the big T traumas that I personally have experienced was kind of dealing with my son's heart surgery. And I maybe that could be little T because technically there may not have been a threat of death, but 5 days old, having heart surgery and a new mom.
It's scary. Yeah.
It was very scary. And, there was 90% chance that he would be fine, and he is fine. He's 8 years old. So we have cardiology checkups, and there's still things to follow up on with that. But I think in the pandemic, I would say more my traumatic experiences have been related to secondary traumatic stress or hearing the stories of my clients. And I've had to go into my own treatment for that. So I think just bearing other people's traumas, I take that on. And that's just a human experience thing. I can't prevent it. So one of those situations was an infant death case where I helped the person work through their personal trauma. And I started to have intrusive imagery and thoughts regarding that particular trauma. And I did some of my own EMDR work around that. I don't know if you want to dig into any of that.
I'm so happy you shared that. I'm also a therapist by training and have an active practice. And one of my clients just said the most sweetest thing to me the other day, because I often say when my clients share their stories, they feel bad sometimes giving me that, like what they perceive as a burden. And I'm like, no, it's my job. I'm fully trained. It's also my job to take care of myself.
Mm-hmm.
And one of my clients pointed out, like one of his job was to review ISIS videos where they were violent and killed or executed people. And so his role had something to do with reviewing those videos. And he pointed out to me, he goes, even though that was my job, that was traumatic. So I know what I share with you is traumatic. So I need your permission to share it. Even though I know it's your job, I still want your permission. And I just thought that was so amazing. He got it, and it helped me. It was just a double reminder of the self-care piece that we need to do as clinicians and coaches and so forth. So I'm glad you brought that up. I'm glad that you are openly discussing going to treatment, because that destigmatizes for other people as well. So yeah, thank you for that. Yeah.
Yeah, I think that's, you're in the field, you probably know, you just have certain traumas that probably you remember more, that stick with you more. And I think at that time I was also pregnant. So with my youngest, who's 6. So there was all these layers for me with that one particularly. And that was probably like 7 years ago. And I had, interestingly enough, I processed that in an EMDR training, which I do not recommend to my fellow clinicians. Do not process a big T trauma or a secondary big T trauma in a training, because yes, I got through the memory and I feel like it was processed, but it could have been held so much differently had I gone to my own EMDR therapist at that point, which I do have now. So this is me talking to myself then, who didn't know what I didn't know, right?
Of course. Yeah.
Yeah.
Yeah. And I think maybe there could be more disclosures when trainers do these type of trainings on what kind of like I was trained in EMDR when it first came out, like by the original gurus of it in the 19 I was gonna say the 1900s, 1990s. Not the 19. I'm old.
Girl,
but
you're taking us way back.
No, in the 1990s. I was like, something about this isn't quite right. And I think I did a little tea, but I was like a little uncomfortable with what it was bringing up in front of like a group setting, because we were doing these in pairs and groups. And maybe it's done differently now. I don't know, but
yeah, I recently went through like an EMDRIA one, so I did that like 7-8 years ago, and then I just went through one in 2020 because I wanted the EMDRIA certification, which I'm very close to getting. So, and that was very different. They're like little T, like traffic, annoyance, just do not process a big T trauma. So they were like, definitely, I think it was very different and held differently.
Okay, that's good to hear, because sometimes I've been turned off with the trainings with EMDR and prolonged exposure to, like, I was a military therapist for 17 years. So I know quite a bit about TBI that you're going to talk about today.
Yeah.
And some of that training, it felt more like, let's stick to this robotic routine of therapy. And it didn't sit right with me sometimes. So anyway, that's neither here nor there, but I'm glad to hear that your experience was different with these newer certifications. But I really want to hear what made you decide to be a therapist? What made you decide about traumatic brain injuries? I think that's the one that, I know actually everything that you do can be applied to the trauma recovery crowd, because
I think so.
Yeah, like, because relationship issues is often a big theme. So the Gottman work is wonderful.
Yeah, and they have some that like a special training for couples who have been through, like one of the partners or both have been through a trauma, and then they're trying to navigate how do we communicate with each other, given that one of the partners has had a significant trauma. So certainly I think it's a nice dovetail.
Yeah. And for the audience members that don't know, because we haven't had many Gottman therapists on, Gottman, they're the gurus for marriage counseling. So if you ever need help with your marriage, a Gottman trained therapist is super helpful.
Yeah. Yes, it's been my favorite couples training, and they're hilarious. Even just their materials, they have a lot of resources people can go through on their own. So it's really great.
Yeah. All right. So what made you decide to be a therapist?
What made me decide to be a therapist? Okay.
if it's okay for me to ask.
No, I'm just like, how do I answer that question? That's where I am right now. Yeah, it's taking me back, a little bit to that moment. So I think, I've always been a helper. I've been, kind of the person in a friend group where like, okay, like, how do we help you through this? And my mom was a psychiatric nurse, so I kind of learned a lot from her and found psychology really interesting. So I think I just kept going to school. I have a bachelor's in psych, and then I got a research master's in psychology, and I thought about academia because I do love research, the research side of things. And then ultimately decided to get my clinical psychology degree and my clinical doctorate in clinical psychology. I'm messing that up, but you know what I'm saying. It's probably in the letters in the bio.
You're fine. You're fine. She's trained people.
Yeah, there's letters. There's a lot of school. So yeah, so I decided I went to a Christian integration program, which is a little bit different than some training programs. So in that program, it's really, I see myself as having a specialty in spiritual diversity because we really looked at how spirituality affects the person, and especially for trauma, I'd say it's something that comes up for a majority of my clients, and that client does not have to be Christian. They can be any faith. And so I've worked comfortably with really any faith, but made it part of their work. If it's important to them, we use it. If it's not, then I don't. Okay, we're not going to use that.
Beautiful. I have the same sort of philosophy.
Mm-hmm.
Yeah, beautiful. Yeah. Okay. Why TBI? How did you get involved with that?
Yeah. So I think I'm this like wondering person in life anyway. I'm like kind of multi-passionate. So this is a theme. So I, had finished up my internship. I had my doctoral degree. And this is my story of moving to Maine too. So during the last economic downturn, I lost my position where I was going to start, sorry, Mike, at my husband's company, and the company went under. So we moved to Maine with a doctorate, and I needed another postdoc here. And I'd interviewed here in Portland, Maine at Goodwill Neuro Rehab, and I was somewhat interested in brain injury, but I knew nothing really. And I think they really wanted a therapist. I really talked about groups and that I loved just working with people. And I think I fell in love with the work once I got there. I loved neuro rehab. I mean, part of me wants to be in a neuro rehab setting still, but I know there's a need in outpatient. So I just really fell in love with working with speech therapists, OT, and really having that integrative approach. So I think my mind really thinks through that lens with trauma and TBI, and the merge of the two is how can we look at the whole person and maybe what their body needs, what resources they may need. So also another role I had was a case manager in foster care. So I also have that side of understanding child maltreatment. So I often think through the lens of case management too. Okay, well, we can't do deep work if you don't have like a steady place to live or shelter, all the food, like the basics need to be met. If we go back to Maslow's hierarchy of needs. So we kind of need to start with that. So yeah, I'm kind of rambly, but that's a little bit about TBI and what interested me. And then I just really kept pursuing that and found that many people coming to me for therapy, there was no other therapist I could refer to. So I found that there wasn't that many trained therapists that also worked within the brain injury community with TBI. And I started to get curious about the problem. Like I kind of felt like I was meandering. There was a few books. There was one of Klonoff. Yeah, Psychotherapy After Brain Injury was one of the texts that I used. And I think it's right here on my shelf.
Sorry for the notes. I'm writing it down.
Pamela Klonoff, I believe, if I'm saying it correctly.
Psychotherapy After Brain Injury. Is that what you said?
Yes. So that was one of the books that I looked through. And so I just felt like, okay, there's a lot of anxiety. Okay, well, let's do CBT. There's a lot of this, depression. Okay, I'll maybe do CBT and some interpersonal, whatever. And I really found that when I saw the client before me, it looked a lot like trauma most of the time, honestly. So most of the folks that I've worked with after a brain injury also have trauma symptoms or have co-occurring PTSD. So it led me to think through, okay, I think I need a trauma modality also underneath my belt because the clients that I'm seeing they have trauma. So it was kind of like meandering through again, which is my theme of how I kind of like, okay, this is interesting. Let's see what this is about. But I didn't feel like as a clinician there was a set path for psychotherapy after brain injury. It's like, okay, yep, these are some of the things that come up, but how you treat it, not too sure.
Right. It's complex too, usually.
It is. It is.
Yeah. Yeah, I learned very early in my therapy practice that almost all of my clients are trauma survivors. I don't think it's an accident that we see people with anxiety, depression, grief, intense grief, relationship problems, communication issues, and TBI. So it didn't surprise me that you were making that discovery. So you mentioned before we came on too that you are a blogger, or writer, and that one of the things that you are working on that's not published yet is TBI and domestic violence with our DV clients.
Yeah.
Is there anything that you're willing to share about that? I know you haven't published yet. Anything you're willing to share?
Yeah, it should be published. So I'm like 99% sure there'll be a link in the show notes that I can give you for your folks.
Yeah.
So I think one of the biggest things I discovered about TBI is that, majority of TBIs come from falls. They don't come from car accidents. They don't come from other things. They don't come from sports. They come majority of the time through falls. And especially for older adults, younger kids, yes, sports, but for older adults, then it's pretty much going to be a fall. However, there is also about 20% of people who sustain a traumatic brain injury from an assault or domestic violence incident. And I think it's probably higher because we know stigma is there with these types of reports that women likely aren't reporting all of those. So it's just really those that are seen in the emergency room. So I just want to give you this quote. So of women reporting to emergency rooms for injuries associated with domestic violence, 30% report a loss of consciousness at least once.
Oh my gosh, that number is crazy high.
Right?
Yeah. Ugh.
And then 67% reported residual problems that were potentially head injury related.
Mm.
And likely I'm thinking, if we just unpack that a little bit. So what does that mean for people that have gone through a domestic violence incident? So 30% have potentially lost consciousness. So a loss of consciousness does not necessarily, they used to think with concussion, rather than back up, that you had to lose consciousness to have a concussion. That is a farce. So we know that even if you do not lose consciousness, you still might be dealing with a concussion, which is a mild traumatic brain injury, or potentially a more severe brain injury. So with a loss of consciousness, that could be a moderate or severe TBI. And if a majority of people, if they've had some issue, a blow to the head, are having issues after that incident, I'm thinking it's going to be hard for them to get treatment because they're in a domestic violence situation. Potentially it's harder for them to get out, to get medical treatment, to get support for the other things that are happening that coincide with the symptoms of TBI.
Yeah. And what my head went to too, if they were physically abused as a child to begin with, they may have already had a TBI from childhood abuse as well.
Right.
Yeah.
Right. And we know that with multiple concussions, so if we're thinking that could have happened, they have had multiple loss of consciousness or multiple concussions, blows to the head. We'll just say blows to the head because I think it's important distinction because people can get wrapped up in that loss of consciousness piece. Then they stack on top of each other. And the trauma, differences in the brain, we know there's changes in the brain that occur after trauma. They also stack with TBI and trauma symptoms together, if that makes sense.
Go ahead.
Yeah. So we know that there's like reduced processing speed with folks after PTSD. So if you've had trauma, likely you have some cognitive changes in your brain that your brain is going to look different than a brain who has not had a major trauma. With that, if you stack a brain injury on top of it, we already know with brain injury, there is reduced working memory, attention, executive functioning, which is the ability for the brain to really put all the things together.
Yeah. Moodiness, mood changes.
Definitely. Mood changes, I think, with TBI and with PTSD. So there's a lot of overlap, I find, with both of the diagnoses. And so it kind of makes sense to treat them together if we've known that that has happened.
Right. Yeah. A lot of my experience has been with IEDs, with the military being blown up. So that's another way to get a TBI other than falling is being blown up repeatedly, or even once we could do it. And so, and that's very common, the TBI with PTSD. And I'm just really thankful you're talking about domestic violence survivors, because I had no idea that, and this is like just what's reported. So
Right, just emergency room.
yeah,
So just what's reported.
likely higher.
Probably more than we know.
Yeah. Yeah. So that's pretty crazy that it's so high. And then when survivors have symptoms, what do? They usually beat themselves up. Like, what's wrong with me? Why can't I remember this?
I'm quote unquote dumb. Like there must be something wrong, when likely there's something neurologically, cognitively happening in the brain. And if it's a concussion, it's a neurometabolic condition. So sometimes with concussion, we won't see anything on imaging. So they might have even had a brain scan and the doctor said, oh, your CT's clear. That does not make any difference for a concussion because it's a neurometabolic condition. That means your cells are affected.
Mm-hmm.
So there's an energy crisis in the brain and there's inflammation in the brain, which also happens with PTSD. So again, I think we have this combining of issues in the brain, and inflammation also happens with depression and other mental health issues. So I just think that it just needs some time, some awareness for people to really, providers, medical folks to look at how these diagnoses can be influencing each other.
Now, you mentioned that when you were on this learning path, that treatment, where to go. And so what did you decide to do for treatment options for TBI, especially what you offer?
Yeah, for what I offer. Yeah, so I offer EMDR for folks who want to address the trauma related to their brain injury. A lot of people after TBI start to have anxiety and panic attacks. So there's a lot of overstimulation that happens with TBI. And interestingly, for the PTSD, there can be some, hyperarousal. So they go to a crowded place and like it's always the grocery store. It seems to come up a lot for folks. And there's a lot of sensory stuff happening. And then they have panic symptoms because then they feel like they're in a dangerous situation when it's not dangerous, but in their body, their body feels like I'm in danger. So they get out of there. And then that repeats over and over again. And they don't go to the grocery store anymore because it seems scary to them. So sometimes I'm working and doing more kind of CBT work with anxiety and panic. I tend to use EMDR without now because I feel like it's just a gentler modality of care where, I'm not just, okay, just go to the store. We do a little of that desensitization or acclimating to that situation in the session and say, okay, well, let's imagine what's the worst picture of the grocery store. Oh, it's when I'm, in the line and I have to, get my money together or, get the card, whatever it is. Okay, hold that picture and then they'll be tapping, or with concussion folks, I never do eye movements, by the way, because that can make them symptomatic. So I will do tapping, or I have little buzzers in my office where that will buzz, usually in their hands. Mm-hmm. And so they're kind of experiencing it in the session with me, like it's happening right now, but they're 1 foot there, 1 foot in my office. So it's always in that window of tolerance and in feeling like they can manage that picture. And if not, then we take a step back. Okay, what is one place in the grocery store you could manage? Oh, well, on the fruit aisle, I like that. And maybe I'm like a 2 out of 10. And the line was more like a 7. So we might start with the other part of the store. Mm-hmm. That makes sense to you.
Yeah, it sounds like like gentle exposure instead of just throwing people on. Yeah.
Yeah.
Yeah. Good. Yeah. Okay. And how do you use biofeedback with your trauma survivors?
Yeah. So I always think of through the nervous system. So I'm also kind of polyvagal informed, where I
Mhm.
look at the nervous system, which I can just give a little overview of the nervous system. So if we're thinking of the autonomic nervous system, we have two branches. We have our sympathetic and our parasympathetic nervous system. So a lot of times with both trauma and TBI, we have a sympathetic dominance. So our fight or flight system, which makes you want to run out of that grocery store, or you're not really going to fight off fruit or fight off anybody. Usually it's a flee situation. We don't really think about like the freeze, which is also part of our nervous system. So sometimes people with trauma and TBIs will, I shut down, I couldn't do anything, or I had to go to the car and I couldn't move. That's actually your parasympathetic that's in shutdown mode, or the dorsal vagal collapse. So it just said, I can't do it. We're going to shut down. But there tends to be more that sympathetic dominance. So you're kind of agitated, you're hypervigilant, you're like, oh, I got to get out of here. You're kind of white knuckling it through the store or whatever situation that's difficult. And so what biofeedback does is it really helps to lower the baseline. So if you're riding high all the time, maybe it's going to bring it down a notch. And I do it through heart rate technology. So looking at heart rate variability
Mhm.
and being able to see when the heart is in coherence. So when you're in a more restorative state. And it's not the goal to stay there forever, because that's impossible. Life is life, and it's normal to experience natural rises and falls in the nervous system. But
Right.
when we don't have any relief, then it's like you're riding high all the time. You're constantly, like I think I've had a client describe like a cat on a tin roof all the time, like ready to kind of pounce.
Yeah, that's exhausting too, being
It's
in
so,
that state for a
well,
while.
and then it's like either the hypervigilance or the collapse for a lot of folks, the freeze response or that kind of fight or flight all the time. And so we want to bring in more renewing emotions. So we do things called attitude breathing, and we're looking at the heart rate technology as they're doing that and trying to breathe in maybe a renewing emotion. If they're feeling frustration, let's breathe in calm and ease. And so by looking at the technology, it really does help, because in real time they can see, oh, I'm seeing this real time change in my nervous system happening. Whereas when I just taught maybe, and not just because breathing techniques are great, but I think the biofeedback does give them that information to make their own changes. So that's how I use it. And I find it's helpful for trauma and TBI. So both struggle with that sympathetic dominance. So both need that different baseline in their nervous system.
Oh, you did such a beautiful job teaching that. Thank you.
Oh, thanks.
Yeah. I hear trainings and descriptions. I'm not trained in biofeedback. That's one of the things I'm not trained in. And so I've heard a lot of people present it over time, and you did it in a really nice way.
Oh, thank you.
Yeah, that was really good. So you mentioned one book so far that you felt helpful in your career.
Yeah.
Do you have any other books that you recommend, either to therapists wanting to learn more, or workbooks or books that you use with clients? That is also very helpful to hear about.
Sure. Yeah. So I think, Bessel van der Kolk's
Mhm.
masterpiece on trauma, but The Body Keeps a Score is probably one of my top recommendations, because we know that, trauma does not live just in our mind. It lives in our body. And I think sometimes people think it's all body, but the mind is important. We're all connected. I like to think of we're all connected. And yes, a lot of that is stored in the body. So thinking through the body has been a big paradigm shift for me as a clinician, to think through, okay, I'm noticing, like when you said that memory, your body, and you braced. Tell me about that brace. And then we'll kind of, process that. Okay, go with that. That's one book. I'm looking right at Body
And
Keeps the
she
Score.
looks at her
I
bookshelf, which I
know.
love.
Yeah. I'm like, what? Oh, I will have to talk about Pauline Boss, I think. So I don't know if you know Pauline Boss's work,
Some of the
Ambiguous
time.
Loss.
Say it again.
Ambiguous Loss
No.
by Pauline Boss. So
Yes.
I wrote about this a little bit in my dissertation regard, and I think it's a nice concept with regard to trauma and TBI. So it works for both. So she talks about losses that are typical, like, and normalized, socialized losses, like the loss of a grandmother or your parent at a kind of typical age. Not that you won't have sadness for that, not that that's not a tragic event in your life, but as socially we know what to do. Okay, I'm going to bring you food, or we have a ritual, we have a funeral, remembrance, whatever it is. We know how to grieve for that. So she founded this model from working with 9/11 survivors.
Mm.
So with people who, survivors or folks who had people at 9/11 whose bodies were not recovered. So that ambiguous loss of my loved one is gone, but I don't have a body. There was no funeral. There was no service. Maybe they did have a service later, but there's this ambiguity in the loss that's really challenging. And how that's helpful for brain injury is a lot of times, one thing we say all the time is, no one really knows. It's the invisible injury. You look fine. There's no changes that I see. And I think from like trauma too, we often don't see any physical changes to the person. They look fine. We don't know they're struggling. And I think with that ambiguous loss of brain injury, they've lost part of themselves. Maybe they've lost a career. They've lost a relationship. And so it's mourning those losses that society doesn't give us a way to ritualize the loss. And so she kind of gives a framework and a model for those losses that aren't prescribed, that we don't have social scripts for in our lives.
Oh, thank you so much for sharing that.
Yes. And she just came out with a new book regarding ambiguous loss in the pandemic, which I highly recommend. And about, our losses, like loss of the graduation ceremony, loss of a celebration of life for loved ones who died in COVID. All these experiences and losses that we collectively have struggled with and how that's impacted other issues in our lives.
Okay. Well, thank you for that.
Sure.
Yeah. So,
and you asked for workbooks. I don't know if we have time for that.
if you have one on top of your head, we'll mention it. If not, you can always email me if you think of one.
I go with like the anxiety and phobia workbook for
That's
anxiety.
my favorite.
Yeah. So I always go with that one, especially for straight kind of panic. It's the anxiety Bible, I call it.
Yeah.
Yeah.
Okay, good. That's an oldie but a goodie.
Yes, it is.
Yes. All right. Well, I'm super appreciative, Dr. Blanchette, that you were on with us today. And where can people locate you if they would like to get to know more about you?
Yeah. So my clinical practice is newlifeofmaine.com. And I'm hoping to join SciPact and maybe offer some more services to folks throughout our country. So not throughout, but wherever that's offered. And also through tbitherapist.com. That is my podcast site. And I'm going to be starting some groups for brain injury survivors in the fall, more coaching style. So either way, I'm at TBI Therapist on Instagram. So you can slide into my DMs if you want to.
Awesome. Thank you again for being here with us today.
Thanks. This was great.
Thank you for listening in today. Please join us next week, same day and time. Also, I would love for you to check out my website, healthrivedream.com.